Welcome, Dr. Wirth. I've been speaking with George, and he's going to handle the Q&As as they come in, the questions, and I guess I'll throw them off to you. But my name is Karen Geisenberger, and we're happy to have you.
Hi, Karen. Thank you.
Okay, so I'm going to
Hi,
mute,
George.
Hi, Dr. Wirth.
I'm going to mute myself and let you.
Okay, well, good afternoon and welcome, everyone. The title of this session is Everything I Want to Know in a Discussion with a Medical Oncologist and a Survivor, but have been too afraid to ask. So my name is George Labonte. I'm the survivor of this panel. I was diagnosed with medullary thyroid cancer in 2016. I am currently enrolled in the LOTSO 292 trial, which has done great things for me. And my co-host here, Dr. Wirth, is my medical oncologist. So let me introduce her by way of her bio. Dr. Lori Wirth is a medical oncologist and associate professor of medicine at Massachusetts General Hospital Cancer Center and Harvard Medical School in Boston. Her research focuses on new treatments for RET-driven cancers, correlates of treatment responses for aggressive differentiated thyroid cancer that is resistant to radioactive iodine and related areas. She is past president of the International Thyroid Oncology Group, and she is also a ThyCa medical advisor. And most importantly, she's a wonderful, wonderful person. So thank you, Dr. Wirth, for being here and volunteering your time to speak with us on this session.
Thank you, George. I just wanted to say that, it's been a real privilege to work with George and get to know him. He's a great guy, and one of the things that one of my colleagues once said is one of the really wonderful privileges of taking care of people with thyroid cancer is that many patients live long enough so that you get to know them very well, and many of them become very good friends. And that's definitely George Labonte in my life.
Well, thank you. And I guess touching on that, I wanted to kind of start this off by talking about trust and that patient provider trust, and how do you go about, so every patient of yours that I've spoken to always speaks so highly of you. They trust the medical advice that you give them. They trust the treatment options you give them. How do you earn that trust with a patient?
Oh boy. I guess I'm lucky that you've only talked to a select patient panel of mine. Because certainly, none of us are perfect. So, I think one thing that is important is honesty. So I do try to be honest at all times with my patients. But, different people need to hear different things at different times. So, brutal honesty and saying everything all at once isn't necessarily the most helpful approach across the board. But still, I think you have to be honest. And it's hard sometimes because many times we're talking about very difficult issues in our oncology clinic. And nobody likes to say difficult things. None of us are wired that way. We're all, wired to be pretty nice people, and to talk about someone's difficult illness is really challenging. I would say honesty is important, and empathy as well. I think it's important to try to understand where the other person is coming from at that moment in time. It's hard to do that. It's hard to do it, especially when you're really busy. There are 20 people out in the waiting room who are all waiting to see you, and you're running 15-20 minutes behind. So it's something that I guess comes with practice.
So, and you kind of answered my next question already, but that was after that trust is established, what strategies might a patient and physician use to help with those difficult conversations? Because, I mean, cancer is a difficult topic, so I'm sure you have had many difficult conversations. What might you do to ease some of that difficulties?
Well, what I would say for patients is that, um, to plan in advance. So I think that, as I said, none of us are wired to really talk comfortably about the difficult things in life. For example, I have a 13-year-old boy right now, and I've begun trying to talk with him about having relationships and intimacy and so forth. And it's really hard for me, but it's also really hard for him. And I don't know what to say. Similarly, talking about the things that worry us the most and that we're most afraid of is really difficult. Those are the kinds of things that we try to avoid at all costs. And really, pushing things under the rug is a really good coping strategy a lot of times. But I think that thinking about these things in advance before you're already out in the waiting room is a good idea, and practicing the words in your head about what kinds of questions you want to ask can be helpful. The It gets easier over time when you put the words to your fears, and it gets easier to talk about those kinds of things the more you think about it and the more you do it. I think the other thing is talking with your family members or your friends can also help along those lines, because, I guarantee you they're worried about the same things that you're worried about. And by talking, by opening up the conversation with them, it'll help you talk about the things that you're really worried about, and it'll help your family and friends talk about those things too. It gives them permission to say what has been, most on their minds, but they really haven't wanted to talk about. And it gives you just the practice in talking about those difficult things that makes it a little bit easier as you go along.
And as you know, I always, between our meetings or appointments, I always type everything into my phone into the notes, list of questions that I might come up with. I'm always asking you, questions like that. So I think that's a great idea to come up, have your questions ready ahead of time. Obviously, physicians are busy too, so you want to make the most of your time.
That list strategy is something that many people do, and it definitely works really well. I think generally the doctor can't get up and walk out of the room if there's a list and you've only done the first one or two things on the list. Having a list will help you think in advance about what you want to talk about, but it will also just help keep you on point, and I think it's a really efficient way to make sure that you've covered everything with your doctor. And it also helps keep your doctor in the room and make sure that he or she is going through everything that's really important to you. And the other thing I'd say is lots of times patients will kind of go through their list, and it'll make me realize, oh, that reminds me something that we should talk about is X, Y, or Z. So it can help prompt your doctor to discuss something that hadn't been in mind.
Now, I know one question that I did not ask you when we first met because I was too afraid. That was, am I going to die? I mean, and if so, how long do I have? 6 months, a year? How do you, when someone asks that question to you, how do you respond to lessen their anxieties?
Well, I knew you were going to say that, and I didn't, I thought, what am I going to say? Because it really is such a difficult question. And I think it goes back to, the idea that talking about these kinds of things is so difficult. I know, George, that asking a question like that is really difficult for you to do, or for anybody to do. And you know, being a medical oncologist, it is something that I've had plenty of practice in addressing, and so that helps, but it is never easy. So usually one thing that I do is, you know, these days everybody's coming to clinic by themselves because of social distancing and COVID-19, which is just an awful situation. But usually, you know, in the regular world, which hopefully we'll be getting back to sooner rather than later, people come not by themselves, but oncology is really kind of a family or friends enterprise. So usually people, especially in you know, when things are when there are new things going on, or transitions or restaging scans, usually people come with a friend or a family member. And so one of the things that I try to do is to figure out from the patient and whoever is with the patient exactly how should we talk about this today, because sometimes people are the people in the room are not all on the same page about, you know, what do I really mean by that question, and how much am I ready to hear, and in what kind of detail do I want to discuss this. And so I try to assess that. And, you know, one of my common phrases is, you know, well, so should we talk about this in terms of hard numbers, or should we talk about things more in terms of general timeframes and general things to discuss. You know, I often will try to normalize it by saying different people are, you know, are comfortable talking about these things in different ways.
And I want to open this up to obviously questions from the group, but I do have one other question for you. And it was your idea to do this session, and I was obviously a willing participant. I thought it was a great idea. And we were tossing around questions back and forth about what might we ask. And one that you sent to me through email, I read over and over and over. And even reading it now, it doesn't make it any easier. It's still difficult. And that is, what do I need to worry about in terms of the end of my life? Now, I think anyone diagnosed with cancer thinks about their own mortality. I know I did. And it certainly gave me a better appreciation for life. And as odd as it sounds, it gave me a better appreciation for death too. So how do you, what do people need to worry about in terms of the end of their life? I mean, it's just, the question itself just marks such a reality of this disease. So how do you allow people to cope with that question?
Yeah, well, so I guess one of the reasons why I thought it would be a good thing to bring up in this session is because it definitely is on the list of, you know, one of the things that's so difficult to talk about. And I think one of the things that people worry about a lot, people's family members worry about a lot. And I think what I found over the years is that that we don't usually start to discuss those kinds of things until people are starting to get really sick, and until the end is nearer. I think that we don't do a good job in our role as helping our patients, helping steer our patients' course, not just about, you know, the drug and the side effects and what's happening with the lesions and the tumor markers, but what else is happening in life. And so, you know, you know, our patients have to worry about how long they might be around, how long might they be able to continue working in the role that they have now in their jobs, what might happen with their family after they're gone. And those are things that are so difficult to really talk about. So I think that beginning to talk with your doctor about those kinds of things um, um, before it's at the last minute really can help our patients kind of have power over some of these things that in a way we don't have any power over. Um, uh, we are striving hard to come up with new therapies that work better and keep people alive longer and are better tolerated. But ultimately, many of the cancers that we take care of still are uncurable. And ultimately, many of our patients still are going to die of their disease. And in many cancer situations, ultimately that is out of our power. But there are so many other things that are within our power to get a handle on and to make better. And end of life planning is one of those things.
Okay, thank you. I do have some questions from the group. This one comes from Marty. It's, do you have an optimum protocol for RAI-resistant Hürthle cell thyroid cancer that has metastasized? Or are you guided by genomic testing?
Well, hi, Marty. One of the things about this Zoom format is that we're not able to see everyone because there's so many attendees. And so I'll look forward to the next ThyCa meeting that I go to in person. For Hürthle cell thyroid cancer, our group and also Memorial Sloan Kettering recently did an analysis of the genomic drivers of Hürthle cell thyroid cancer, and most Hürthle cell thyroid cancers don't have the kinds of actionable mutations that we see now in some other thyroid cancers, like medullary thyroid cancer, for example, most of which have actionable RET mutations. We haven't quite made breakthroughs in that regard with Hürthle cell thyroid cancer, but there have been some advances nonetheless. First of all, the multi-kinase inhibitors like lenvatinib and sorafenib have pretty good activity in Hürthle cell thyroid cancers. And then it also looks like a combination of an MKI like sorafenib with another drug that inhibits the mTOR pathway like everolimus seems to have good activity in Hürthle cell thyroid cancers. And that's work done by Eric Sherman at Memorial Sloan Kettering. There's also some interesting data that's emerging that Hürthle cell thyroid cancers may be a little bit more responsive to the immune checkpoint inhibitor therapies that now have been studied across multiple different types of cancers. In differentiated thyroid cancer that's iodine refractory in general, those cancers don't tend to be very responsive to the immune therapy drugs, but it looks like there may be a signal in Hürthle cell thyroid cancer. So I think there's more study that needs to be done in that regard.
Thank you. Next question might be a little bit more difficult for you to answer, but it's from Sue M. And when asking my doctor what my prognosis is for metastatic, poorly differentiated thyroid cancer, she says, quote, "It may shorten my life," end quote, and doesn't go past the 5-year mark. As she says, that is what the statistics say. Do they tell you the truth?
Well, so like I said earlier, I think different people have different ways of talking about these kinds of things. And that's true not just for patients and their family members, but also for doctors. So of course you want your doctor to be honest with you. But, some doctors too are more or less comfortable talking about these kinds of things. I think that, the way that your doctor may have phrased that sounds fairly consistent with what we know about average or median survival of people with iodine refractory poorly differentiated thyroid cancer. So I think that that was a, that was an on target kind of question. I think sometimes we get answers from our doctors that are vague and sort of not really answering the question that you want to answer. If you want to know how long do you think I'm going to live with this disease where I'm at now, and your doctor says, well, people can live for 5 or 10 years. You can say, I know, but what about me? What do you think about me? You can, come back with another question. Another thing that I would say is that don't ever be afraid to ask your doctor anything. Don't ever be afraid to ask follow-up questions. In the old-fashioned world, people listen to their doctors like they were, super special human beings. And they, there was an idea that you have to do what your doctor tells you and so forth. We're just average people like everybody else, and you should not be intimidated by your doctor. You should not be afraid to ask your doctor anything. And you're an equal. You're more than equal, because you're the patient in the room, and it's all about you when you're in the room with the doctor. So if your doctor is maybe in a hurry and is trying to skirt a difficult conversation, it may be that he or she can't really sit down and spend an extra 15 minutes with you at that moment in time. But you can say, hey, I really want to talk about these things. They're really bothering me and worrying me a lot. Can I have an appointment with you sometime in the next couple of weeks just to sit down and talk? Totally legit.
Yeah, that's good advice. The next question comes from Jane. Is it frequent that unstimulated thyroglobin levels are low or undetectable, but there's an FNA evidence of multiple tumors / positive lymph nodes? Is a tumor not producing thyroglobin a poor prognostic factor? And she put in parentheses, no detectable antibodies.
Mm-hmm. So yeah, in general, that's true. It's really hard for me to comment on a specific case without knowing all of the details. But it's a little bit unusual to have differentiated thyroid cancer, like papillary thyroid cancer or follicular thyroid cancer, or Hürthle cell for that matter, that where there are deposits of tumor that can be seen like on an ultrasound or a CT scan. And those cancers don't produce any level of thyroglobulin. And it's also true that the iodine refractory thyroid cancers that don't produce much thyroglobulin tend to be more aggressive. It goes along with them being less well differentiated in general, and the less well differentiated the cancer in general, the more aggressive it is.
Just as a follow-up to Sue's question, she said that this is a question before the last one I asked. My doctor said they measure this in 5-year intervals, not that she thinks I will die within 5 years from this. I'm finding it very hard to plan anything in the future. Next question comes from Heather. She said, I have papillary thyroid cancer and I'm 3 years post full thyroidectomy, had RAI, and my thyroglobin has always been detectable but low. For the past 3 years, my thyroid hormone has been unbalanced, going from hypothyroid to hypothyroid month after month. I am very asymptomatic, and I am now under the care of a new endocrinologist who has me on NDT. I am super sensitive to T4 and T3. I am a strong advocate. I talk to my doctor, have a therapist, and a member of the online ThyCa boards. What can I do to work on getting my thyroid numbers balanced while being sensitive to T4 and T3 and really having a hard time with mental health challenges due to medication adjustments? This has been a big battle for me.
Yeah, so I don't know, unfortunately, if I'm going to be able to help all that much because as a medical oncologist, my understanding of thyroid hormone balance and replacement is not nearly as refined as that of an endocrinologist. So, I think I would have to just defer that question to somebody who's a card-carrying endocrinologist and not me. One thing I would say though about the thyroglobulin level, in patients with differentiated thyroid cancer who have a low but measurable thyroglobulin level, what that suggests is that there probably are, and who've had radioactive iodine, what that suggests is that there probably are a couple of thyroid cancer cells kicking around someplace. But if that's all that is present, is a low but measurable thyroglobulin level, usually the life expectancy is normal. Usually the people in those categories don't develop progressive thyroid cancer that's going to make them sick in the future. So it sounds like in that regard, the prognosis is pretty good.
Next question, it comes from Sarah. We spend so much time talking about prolonging life. How do you help patients find the right time to let go?
So Sarah, hi. Another really good question. There are lots of questions. I hope that we have a chance to get to them all because they're all so good. So this is something that is very hard for people. Nobody is ever ready to let go. Nobody is ever ready to die. Nobody's family member is ever ready to have their loved one pass away. And it doesn't matter if you're 45 years old or if you're 85 years old. Believe me, 85-year-old people usually want to keep on going as long as possible as well. One of the phrases, in addition to not being ready to let go, that I've heard a lot is not ready to give up. People want to keep on fighting. And again, nobody's ever ready to give up. Nobody's ever ready. Nobody ever wants to throw in the towel, particularly in this kind of a fight. And one of the things that I have felt over time is that often well, two things. Often people are of two minds. Often people have suffered a lot when they're so sick that they begin thinking about the end of their life. And often people want to keep on going, don't want to die, but at the same time have been suffering a lot. And eventually, quality of life really is quite diminished and there can be, pain or other suffering. And so so often people say, I don't want to die, but they've been suffering too much. And in some ways they kind of feel more ready to go. And so I've often talked about those two polar opposites that people have and are struggle with at the end of life. And then the other thing that I think is that you don't have to throw in the towel and you don't have to give up. You can keep on fighting. But sometimes we need to think about what are the things that are realistic to keep on fighting for, and what are the things that you as a patient most want to keep on fighting for. When people are in the hospital and they're sick and they're uncomfortable, and they're away from their families, many people want to be at home and many people want to spend as much time as possible with their family for as long as they can. And so we talk about those kinds of things. What are the goals and what are the things that you want to keep fighting for, and let's see if we can figure out ways to fight for the things that we can continue to fight for as hard as possible. And often that will help kind of reframe a discussion so that rather than thinking that, for example, hospice is just awful and the last thing that anybody would ever want to do, which in many regards is true, but sometimes hospice, being at home with the help of hospice and being with your family and friends really is the most important thing for a patient when you really kind of reframe the things that people are struggling with.
Good answer. Next question comes from Jess. And does having a certain type of thyroid cancer or certain characteristics of the cancer put me at higher risk for reoccurrence or developing anaplastic type? Should ultrasounds continue to be done every year, even if labs thyroid globin look good?
So, Jess, I may not be able to answer the question too specifically, again, without knowing all of the details. It's really hard to be able to answer specifically. But in general, when patients have had surgery plus or minus radioactive iodine for differentiated thyroid cancer and have not had a disease recurrence by 2 years or by 5 years, the prognosis really is very good. There are features that do increase the risk of recurrence in the future, like if there's extrathyroidal extension or many lymph nodes involved or extranodal extension. And so I think that having those kinds of things are in the pathology report. So one thing that you might want to consider doing is getting your pathology report from your thyroidectomy from your doctor and bringing it into the next visit with him or her and saying, you know, I want to talk about, you know, what my prognosis is and whether my cancer is at risk for coming back. And if we talk about the specifics here with my cancer and my path report, what do you think? That might be helpful. The risk of dedifferentiation to anaplastic thyroid cancer is real, but very small. We only see that in people who are living with structural differentiated thyroid cancer that's iodine refractory. And structural, by that I mean lesions that we can see on CT scans. We don't ever see it in people who've had a thyroidectomy and plus or minus radioactive iodine, don't have detectable thyroglobulins, and don't have detectable lesions on scans.
The next question comes from an anonymous attendee, but it's, I have a surgeon, no onco. Not dealing with high tumor load, but feel like there's a team member missing as endo is not a specialist in medullary thyroid cancer. Do you have a suggestion for a team leader in addition to me, or think there's a good time that there's a time, good reason to involve an onco?
Oh, what a great question, Anonymous. And I like how you said that you're the team leader. I like that, right up my alley. Most people with thyroid cancer don't need to have a medical oncologist at all. You know, it would be great if medical oncologists could be put out of business when it comes to thyroid cancer altogether. People who do have advanced thyroid cancer, I think, can benefit from having a medical oncologist as part of their team. I think it's really important for the medical oncologist to work in collaboration with the other team members, particularly an endocrinologist and surgeon. And not just simply take over the care of the patient. And sometimes that kind of thing happens. It's hard for everybody to be well coordinated when working together as a team. But if there are new treatments for medullary thyroid cancer that may be changing the landscape for when to start therapy in the future. These are things that we're really still figuring out. But if you have, for example, measurable and even increasing calcitonin and CEA levels, but no disease that's seen on scans, there's probably no urgent need for systemic therapy. We're hopefully going to be doing clinical trials in the future looking at people who have rising calcitonin and CEA levels with some of the newer drugs in medullary thyroid cancer. So there are going to be more clinical trials, and then also perhaps initiation of therapy, systemic therapies earlier, now that we have drugs that have a better side effect profile. It can't hurt to have a consultation with a medical oncologist at any time.
Next question comes from Jay. I have liver and bone mets, BRAF, and TERT and tall cells, which all indicate a poor prognosis. What does poor prognosis mean?
Well, yeah, so I think just in general, that phrase poor prognosis means in the context of thyroid cancer, that people who have a poor prognosis are more likely to die of their thyroid cancer than live with their thyroid cancer and die of some old age thing. So I think in general, that's what poor prognosis means, but it's really hard to be specific because one of the things that's different about iodine refractory thyroid cancer, also metastatic medullary thyroid cancer, is that people can live for many years. So, with a median statistic of median overall survival, say it's 7 years with iodine refractory differentiated thyroid cancer. So that means that half of the patient population with that diagnosis will live longer than that, and half of the patients will live shorter than that. So the median survivals in advanced thyroid cancer are a lot longer than they are in many other types of metastatic cancer situations, like lung cancer, for example. So a poor prognosis lung cancer is different than a poor prognosis thyroid cancer. Usually with poor prognosis thyroid cancer, still people are going to live for many years.
The next question is from Mary Ann. For patients with HERSC cell carcinoma and have no targetable mutations, which meds are having the best response when lenvatinib is not tolerated at therapeutic levels? Thyroglobin doubling time is about 5 months. Tumor growth doubling time is about 6 months.
Mm-hmm. Well, if lenvatinib can't be tolerated at the standard dose, there still often is activity on when you have to reduce the doses for side effects, and it's very common that the dose has to be reduced because of side effects that are not tolerable. That's par for the course with lenvatinib, but lenvatinib can still have activity when it's not at 24 milligrams a day. It can have activity at 20, 18, 14, 10. I think when you get below 10 milligrams a day, it's less likely to have any real activity. If lenvatinib, if the cancer is not responding or progressing on lenvatinib, then there are second line therapies. Sorafenib has some activity. As I mentioned, there was a clinical trial looking at sorafenib and everolimus that showed some activity, particularly in HERSC cell thyroid cancers. So that's not, sorafenib and everolimus is not FDA approved, but might be something that could be considered off-label. And then I mentioned the checkpoint inhibitor data, which looks somewhat promising in particularly in HERSC cell thyroid cancer. One thing I would say is that that's also is not FDA approved, and we don't know enough yet, but we do know that pembrolizumab, which is an immune therapy, is FDA approved for people who have a high tumor mutational burden. So that might be one test that could be done on a HERSC cell thyroid cancer to see if there would be on-label coverage for a drug like pembrolizumab or Keytruda.
So the next question is from an anonymous attendee. I got diagnosed 2 weeks before my wedding. Since then, it's been surgery, appointments, nuclear scans, and just general worry about future prognosis. By the time my husband and I were comfortable with the idea of starting a family, my calcitonin has increased and now I need another nuclear scan. My question is it worth starting a family if, God forbid, I end up leaving my kids orphaned? Should I consider dealing with the decisions not to have any children and just focus on my health?
Well, congratulations on your wedding. That's really a lovely thing. And George, I think you have to answer that question. And I just realized I've been talking way too much. Yeah. George, you can answer that. You've got great insight in that regard.
So, I mean, with my own experiences, I was diagnosed, I had 3 children, and my wife and I, we always wanted 4 kids. I had the surgery, radiation to neck and chest. Things were going pretty well, and then I had a spot pop up in the middle of my spine, which is radiated. I guess the point of it is that my wife and I decided we wanted to have 4 children, and we didn't want cancer to get in the way of living our lives, which is why we ended up having a 4th kid, which is the terror of the family, but that's besides the point. So, I mean, if it was me, my wife and I, we had a long discussion about it. And like I said, we didn't want cancer to get in the way of our life decisions. We just kind of take it as it comes now. Fortunately, LOXO 292 became available as the disease started to progress even more. And I got more mets to my hips and ribs and liver, but I've been doing great on the LOXO 292, the subacatinib now. So I just keep kicking that can down the road until that cure comes out. So I guess for me, I just didn't want cancer to make my life decisions. You know, I'm still planning for retirement at age 55, which is 15 years away. You know, I'm such a planner that I want to plan for these things. And if life ends up changing, then I'll just change with it, I guess, is the best way I can answer that. Okay.
That was a good answer.
Here is a good question. This is a bit off topic, but is anyone doing good research advancing on vocal issues and/or throat issues? I want to have a voice in the future, also concerned about sleep apnea. I can say for me, the LOXO 292 gave me my complete quality of life back. I ran the Boston Marathon last month. I'm physically active. The one thing for me that I don't feel right about is still my voice. It's still my voice. Now, I don't know if it will ever get better. And it's been, like I said, it's been 4 years now. And I don't think so much the surgery, but I think it's more the radiation that affected it more than anything. But it's the constant clearing of the throat. It's the graveliness at night. And I catch any cold or virus or even allergies, my voice just ends up being horrible. So I like this question about research on vocal issues and other throat issues. I mean, even I'm sure people have seen as I swallow, I have to tuck my chin in order to swallow. You know, that's just habit or what. But can you?
So, so there are, so that's, the hoarseness is something that that I think in our endocrinology clinics, medical oncology clinics, even in the, general endocrine surgery or ENT or head and neck clinics, we don't really think about too much. George, your voice, I think, is great. Sure, it's gravelly, you have hoarseness. We know that there's what the vocal cord is like. But it's easy for me to think that's a completely workable voice and should be a total non-issue. And so this is a kind of thing that physicians may often just not think to address at all, because your voice is workable. You haven't had trouble with aspiration pneumonia. And so if you have some swallowing impact because of a vocal cord not working so well, to me, from my perspective, it seems totally doable. And so that I don't mean to minimize this at all. It's just that often, these are the kinds of things that are not foremost in our mind when we're addressing the cancer problem, but they really do matter too. These are quality of life things that are really important, but might not be something that comes to mind immediately with your doctor when he or she is seeing you. There are good laryngologists or larynx specialists who can work wonders with voice issues. There are also speech and language pathologists who can really help a lot with voice quality and swallowing problems when swallowing is impacted on by thyroid cancer. ask for a referral. And there, you know, a general ENT person in a community may not have lots of specialized expertise in addressing these issues, but there are people in larger referral centers that do have tremendous amount of expertise. You know, in Boston, there are several groups where we have ENT doctors who are larynx specialists who can do procedures specifically related to voice and vocal cord dysfunction that our general even our general really good head and neck or endocrine surgeons really can't do. So ask to see a larynx specialist.
Yeah, and it's a good way to put that in perspective, because there's a earlier session, I think Friday, with Dr. Gagel, who it was the option whether they keep their voice box or not. You know what I mean? And you know, here I am complaining about a little gravelly voice when some people obviously have it a lot worse. So it's a good way to put that in perspective. From Robin, just a comment. We need drugs to target NRAS mutations for poorly differentiated thyroid cancer. Unfortunately, I just lost the question. Unfortunately, my husband's medical doctor won't give him a quote unquote timeline for end of life. We have asked. Thank you for all you do. What is the longest you've seen a poorly differentiated thyroid cancer patient last on various TKIs? Give us hope.
Well, yeah, so I've had many patients with poorly differentiated thyroid cancer who respond very well to treatment, and so often poorly differentiated thyroid cancer can do as well as a you know, as a like a higher risk papillary thyroid cancer subtype, say Hobnail variant or tall cell variant. We've seen in both the lenvatinib and sorafenib trials that can certainly happen. Poorly differentiated thyroid cancer doesn't always behave that way. However, sometimes it is more aggressive. So I hope that your husband's case is more the former than the latter. One thing I would say is that the pharmaceutical industry has a lot of really smart people working to develop new drugs. And, you know, the pharmaceutical industry can make a lot of money and charge a lot of money for these new cancer therapies. You know, it's kind of a crazy amount of money sometimes, but the science that is funded by these large dollars is really truly remarkable. And targeting RAS is something that multiple large and small pharma companies are working on. So there is real interest in coming up with drugs that will be effective in KRAS, NRAS, and HRAS-driven tumors. So keep on asking about clinical trials, and you can always do a consultation if you can't travel to a big thyroid cancer program. You know, there are a number in the U.S. There are many large hospitals that have remote consultation services. So you can always do a remote consultation with an expert in the field and find out what that person might know about clinical trial options that might be emerging in the not too distant future.
We got about 10 more minutes, and I just want to get through a few more of these questions. This one comes from Eva. Now, I just heard you mention Hobnail. Eva asks, what's the difference between Hobnail and anaplastic cancer? My papillary cancer had 3% Hobnail. What does this mean?
So, so that means that you have papillary thyroid cancer with Hobnail features. And in order to be called a Hobnail variant, there has to be a higher percentage of features. So it sounds like the pathologist that looked at the cancer was a really good pathologist and was being very descriptive. And the more that's in those pathology reports, the better in general. You don't want to get a thyroid cancer histology report that says papillary thyroid cancer, and that doesn't say anything else than that. So 3% Hobnail variant probably is okay in terms of that not being a significant negative prognostic factor. Hobnail variant papillary thyroid cancers do have a slightly worse prognosis, but 3% of Hobnail cells doesn't count as that variant. And I think any papillary follicular Hürthle cell poorly differentiated thyroid cancer can devolve into an anaplastic thyroid cancer, but as I said earlier, that's a rare phenomenon, and not more likely in this case with a 3% Hobnail, with 3% Hobnail features.
As a caregiver who is also a survivor of the same cancer, Hürthle cell, what advice do you have to support the patient, my mother?
Well, you know, it's hard to know what your mom's needs might be, where she is in terms of her overall cancer situation. So it's hard to speak in specifics, but you know, one thing that I'd encourage you to do is to talk to your mom and to keep on probing and keep on asking questions, and you know, one of the things that I think one of the ways, asking questions that are open-ended and neutral, but sort of give permission to have people say things that are difficult to say, is a good strategy. So, you know, one good question is not just how are you doing today, but what are the things that are on your mind today? What are the things that you're worried about? And then going from there. Another thing is, you know, we're trained to not ask for help. We don't want to burden other people. And many of our parents or our brothers and sisters don't want to be a burden to anybody else, particularly their kids who they love and they've always wanted to be able to take care of. But letting your mom know that you really want to help her, and it means a lot to you to be able to help her, might give her permission to lean on you a little bit more than she'd otherwise be comfortable doing, because she doesn't want to be a burden to you.
That's great advice. Next question. I have been in remission from anaplastic thyroid for 30 months after chemo and radiation. No one knows how long this will last. Any suggestions on dealing with the uncertainty and fear?
Oh boy, that's a great question. And George, I might throw it back at you in a minute, but let me say one thing. So usually anaplastic thyroid cancer, when it comes back, it usually comes back very quickly. And if a patient has made it to the first year mark without a recurrence, that's good. If a patient has made it to 2 years and the cancer hasn't come back, the prognosis is even better. And there are people who survive anaplastic thyroid cancer. If you're disease-free after 30 months, that's actually pretty good. And I would feel much more encouraged about the long-term prognosis in that situation than I would be at 6 months or a year. So more power to you. But George, what do you say? Like, how do you deal with the uncertainty? I think uncertainty is one of the hardest things to deal with.
And it is. And last week when I saw you for my regular appointment, I had some hip pain 3 weeks prior to seeing you in the scans, and always the paranoia of, oh my gosh, is this bone mass, is it taking me off? You know, I haven't had my calcitonin in 12 weeks. You know, is that going to show an increase? What are the scans going to show? So I think that level of paranoia and fear is normal in a way. But I think it's important to kind of keep that in check, and still you need to live your life. And there's things that you can control in life, there's things that you cannot control. And I think when we start focusing on the things that we can control, like staying healthy, eating right. I know there's a session on nutrition and exercise. Those things you can control, and you'll feel better about yourself if you do them. Things you can't control is reoccurrence, and necessarily you can't, you know, control that. But it's still normal to have fear of those things, but to worry incessantly about it, I think ends up being more of a detriment than just living your life and just kind of taking the day as it comes. I know, you know, it's that expression, one day at a time. You just gotta appreciate it every day, one day at a time. Okay. what time is it? We got about 3 minutes. Hello, thank you for your time. I am 59 and I had my first surgery 5 years ago and had 15 lymph glands with my thyroid and 2 parathyroids removed, papillary thyroid cancer. Currently, on an ultrasound, I have 4 spots. My antibodies are increasing and are in the 30s. They were negative last year. I'm wondering if I have a faster growing thyroid cancer and I'm able to have more, and I am having more trouble swallowing. They did try an FNB 2 times and both inconclusive due to the depth and position. I'm wondering what other scans or evaluations I should be looking into. Thank you.
Mm.
So I think she's just looking to see what other forms of imaging or tests you might be able to have.
Yeah. So this is one of those situations where, again, hard to speak specifically, but sometimes the test of time is the best test, and it's really hard to sit back and wait and repeat something in, say, 6 months from now. But the often comparing apples to apples is useful. So a follow-up thyroid neck ultrasound may be the most useful test if done in far enough away so that there's a chance for some interval change. These could be reactive lymph nodes to some minor cold or infection or something, or some other inflammatory thing. Having dental problems can cause some lymph node inflammation, or they could be a slow recurrence of the thyroid cancer. And if a time period of 3 to 6 months goes by and a repeat ultrasound is done, that might be enough time for there to be enough change to have a clue about what's going on there.
And we can just squeeze in this last question. Is there palliative treatment short of hospice?
Yes. So that's a great question. And there are palliative medicine is a relatively young field, but it's a growing field. There are a lot more people developing expertise in palliative care, and palliative care is by no means the same thing as hospice. Hospice is, I think, a small piece of that pie, and people who have expertise in palliative medicine really are interested in helping patients have the best quality of life as possible. And there's so many different ways of doing that, with good pain control, other good supportive therapies, helping manage a difficult nausea and vomiting problem, for example. So there's a wide range of ways that we can help people with cancer have better quality of life. And it doesn't have to be by a palliative medicine specialist, but it can be. And there are a lot of those specialists that are out there, and they really want to be able to help in that regard.
Okay, well, we're out of time, and I apologize if we didn't get to your question. Thank you for all listening, and thank you to you, Dr. Wirth, for all your expertise and knowledge. This is great.
George, it's great to see you again. I love doing things like this with you. I think we're going to have to make this an annual thing.
That sounds good to me. Thank you so much, everyone.
Thank you, everybody. Again, I hope that we're seeing each other live in person soon.